Welcome to NEJM This Week. I'm Dr. Lisa Johnson. This week, we feature advances that may change care for prostate cancer, multiple myeloma, acute pain, and IgA nephropathy. We review platelet factor 4 disorders and follow a case of persistent nasal ulceration. Perspectives explore medical aid in dying, federal authority in healthcare, public health and litigation, and the challenge of delivering life-changing news with honesty and compassion. PARP and androgen signaling inhibition plus ADT in metastatic prostate cancer by Neeraj Agarwal from the University of Utah, Salt Lake City and co-authors. With an estimated 1.5 million new cases of prostate cancer and 397,000 deaths from prostate cancer worldwide in 2022, prostate cancer is a leading cause of death from cancer among men. A previous trial involving patients with metastatic prostate cancer that was resistant to androgen pathway modulation showed that adding the poly-ADP ribose polymerase PARP inhibitor talazoparib to the androgen receptor pathway inhibitor enzalutamide significantly improved imaging-based progression-free survival and overall survival, with the greatest benefit observed in the cohort with alterations in homologous recombination repair genes. In this ongoing Phase 3 trial, 599 patients with metastatic androgen pathway modulation-sensitive prostate cancer harboring alterations in homologous recombination repair genes were randomly assigned to receive talazoparib plus enzalutamide or placebo plus enzalutamide once daily. Talazoparib added to enzalutamide led to significantly better imaging-based progression-free survival than placebo plus enzalutamide among these patients. Serious adverse events were more common with talazoparib plus enzalutamide than with placebo plus enzalutamide. Rana McKay from the University of California, San Diego, La Jolla, writes in an editorial that the trial by Agarwal and co-authors has made an important advance that will reshape the treatment of advanced prostate cancer. Translating the findings into practice requires examining the enrolled population, biomarker selection, efficacy, and safety, while situating the trial within the broader landscape of Phase 3 trials of PARP inhibitors and the evolving treatment intensification focus in patients with metastatic androgen pathway modulation-sensitive disease. The trial by Agarwal and the recent Phase 3 Amplitude trials underscore the imperative for universal genetic tumor testing in all patients with metastatic prostate cancer. As PARP inhibitor-based combinations and other biomarker-directed therapies become central to the management of advanced disease, comprehensive molecular profiling at the time of diagnosis of metastatic disease is essential to ensure that all eligible patients have access to precision treatment. Together, these recent advances usher in an era of precision intensification in which biomarker-driven therapy is delivered earlier and more effectively across the prostate cancer continuum. Future trials will likely build on these foundations. Teclistamab in multiple myeloma with 1 to 3 previous lines of therapy by Cyril Touzeau from the University Hospital of Nantes, France, and co-authors. This study evaluated the efficacy of teclistamab, a bispecific antibody targeting B-cell maturation antigen and CD3 as early-line monotherapy in relapsed or refractory multiple myeloma. 593 patients with relapsed or refractory multiple myeloma who had previously received 1, 2, or 3 lines of therapy, including an anti-CD38 monoclonal antibody and lenalidomide, were randomly assigned to receive teclistamab or the investigator's choice of pomalidomide, bortezomib, and dexamethasone, PVD, or carfilzomib and dexamethasone, KD. This patient population has been underrepresented in clinical trials to date. Teclistamab monotherapy significantly improved progression-free and overall survival as compared with PVD or KD among these patients. Adverse events were common. Diligent infection prophylaxis and immune globulin replacement are critical for infection management, given the potential for serious infections. In an editorial, Maria Victoria Mateos from the University Hospital of Salamanca, Spain, writes that the implications of this trial by Touzeau and co-authors extend beyond efficacy and provide a critical benchmark for understanding outcomes in patients with disease refractory to lenalidomide and daratumumab, given that nearly 3/4 of the trial population had dual refractory status. The relatively poor performance in the PVD or KD group, median progression-free survival 8.2 months, reflects the reality of this population of patients with refractory disease and challenges the continued role of these drugs as standard care options. The trial by Touzeau is a landmark trial that not only shows the efficacy of teclistamab monotherapy, but also highlights the evolving reality of early relapse in multiple myeloma. With BCMA-targeted therapies now established as a cornerstone approach at first relapse, the focus must shift to optimization. Teclistamab monotherapy offers a pragmatic and accessible approach, but its broader use will depend on improving safety, particularly with regard to infections, and refining patient selection and sequencing of treatment. Phase 2b trial of an NaV1.8 inhibitor for acute pain by Neil Singla from the Litigo Biotherapeutics, Thousand Oaks, California, and co-authors. NaV1.8, a voltage-gated sodium channel expressed in the peripheral nervous system, has a critical role in pain signaling. Previous trials of NaV1.8 inhibitors have shown effectiveness in reducing post-operative pain. In this Phase 2b trial, 343 patients with moderate to severe pain after abdominoplasty, commonly known as a tummy tuck, were randomly assigned to receive a 300 mg loading dose of the selective NaV1.8 inhibitor LTG-001, followed by 150 mg every 12 hours, low-dose group, a 450 mg loading dose of LTG-001, followed by 300 mg every 12 hours, high-dose group, hydrocodone bitartrate acetaminophen every 6 hours, or placebo every 6 hours. All doses were administered orally over a 48-hour period. The median time to meaningful pain relief was no more than 1 hour for both LTG-001 dose groups. LTG-001 led to significantly greater reductions in pain scores than placebo over the course of 48 hours after abdominoplasty. Iptacopan in IgA nephropathy, final 24-month data by Jonathan Barrett from the University of Leicester, United Kingdom, and co-authors. IgA nephropathy, a progressive, heterogeneous, and immune-mediated kidney disease, is the most common primary glomerulonephritis worldwide. Despite current standards of care, up to 50% of patients with IgA nephropathy have progression to kidney failure within 10 to 20 years after diagnosis. Overactivation of the alternative complement pathway contributes to IgA nephropathy and glomerular inflammation. In a 9-month interim analysis of this Phase 3 trial, iptacopan, a complement factor B inhibitor, led to a significant reduction of 38.3% in the 24-hour urinary protein-to-creatinine ratio as compared with placebo, and had an acceptable safety profile. The authors now report on the final 24-month data. 477 adults who had IgA nephropathy, an estimated glomerular filtration rate, eGFR, of at least 30 milliliters per minute per 1.73 meters square of body surface area, and a 24-hour urinary protein-to-creatinine ratio of 1 or higher despite supportive care, were randomly assigned to receive oral iptacopan or placebo twice daily. Iptacopan therapy led to a significant reduction in kidney function decline among patients with IgA nephropathy at high risk for progression. Platelet-activating antiplatelet factor 4 disorders. A review article by Theodore Warkentin and Andreas Greinacher from Stanford University, Stanford, California. Platelet-activating antibodies against platelet factor 4, PF4, cause highly prothrombotic disorders with reduced platelet counts. Anti-PF4 disorders cause severe thromboinflammation that results in self-enhancing activation pathways of innate and adaptive immunity and hemostasis. The prototypic anti-PF4 disorder is heparin-induced thrombocytopenia, HIT. In 2021, heparin-independent platelet-activating anti-PF4 antibodies were identified as the cause of vaccine-induced immune thrombocytopenia and thrombosis, VITT, a complication of adenoviral vector COVID-19 vaccines. In rare cases, an immune thrombocytopenia and thrombosis disorder that is clinically nearly identical to VITT can be caused by natural adenovirus infection. HIT and VITT display two distinct immunopathobiologic profiles. Accurate diagnosis relies on distinct assays for HIT and VITT antibodies. The combination of thrombocytopenia and thrombosis may prompt consideration of an anti-PF4 disorder, especially in an appropriate clinical context, such as recent or concurrent heparin treatment, bacterial or viral infection, or knee replacement surgery. Clinicians need to be aware of the locally available screening tests for anti-PF4 antibodies in light of the differences in test sensitivity for HIT and VITT antibodies. A 37-year-old woman with persistent nasal ulceration. A case record of the Massachusetts General Hospital by Stacy Gray and colleagues. A 37-year-old woman sought care for a painful crusting sore inside her right nostril that had persisted for 17 years. The lesion bled intermittently, required frequent removal of scabs, and gradually enlarged until it occasionally interfered with breathing. Despite years of topical treatments, her symptoms recurred. Endoscopic examination revealed marked crusting and ulceration involving the right inferior turbinate and septum in a multifocal distribution. She otherwise felt well, without fever, weight loss, or other systemic symptoms. As a child in Honduras, the patient had had a non-healing skin lesion that eventually resolved after treatment with what the patient described as hot metal, a description consistent with cautery treatment. The patient reported that her mother had had a similar recurrent lesion in her nose. This history provided important clues. A biopsy initially showed chronic inflammation with poorly formed granulomas, and specialized molecular testing ultimately identified Leishmania brasiliensis, establishing the diagnosis of mucosal leishmaniasis. The patient was treated with intravenous liposomal amphotericin B. Although therapy was complicated by mild kidney injury and nausea, follow-up showed progressive healing with resolution of nasal inflammation and crusting, and she remained clinically well. The Paradox of Medical Aid in Dying. A perspective by Mara Bookbinder from the University of North Carolina at Chapel Hill School of Medicine. Legislative support for medical aid in dying, MAID, in the United States is growing. In the past year alone, 3 states, Delaware, Illinois, and New York, have legalized the practice, bringing the number of permissive jurisdictions up to 14, 13 states plus the District of Columbia. Nearly 1/3 of the U.S. population now lives in a jurisdiction in which MAID is legal, permitting authorized clinicians to prescribe lethal medication for terminally ill patients, provided that certain regulatory requirements are met. That is, the patient is an adult with a survival prognosis of 6 months or less, is mentally competent, can self-administer medication, and, in some jurisdictions, is a state resident and has waited for a prescribed period. And yet, despite this significant growth, there is a paradox at the heart of MAID. One of the key ethical arguments driving MAID legalization in the United States rests on the assumption that it will remain a rare event. In U.S. jurisdictions with the longest history of MAID, utilization rates are exceptionally low, but the clinical implications of MAID stretch further than the utilization statistics might suggest. Many more patients request MAID from a physician than go on to use it. Some patients who request it are ineligible, and some merely want to have medication on hand for reassurance. Studies of clinician-patient interactions have also revealed that MAID is often a starting point for deeper conversations about end-of-life concerns. As a cultural phenomenon, MAID invites creative thinking about what the demand for it reveals about how people die in America today. Its ascendance suggests that many Americans want more opportunities to plan for their deaths and to infuse them with personal meaning. Medical Standards by Federal Fiat. A perspective by Benjamin Barsky from the University of California College of the Law, San Francisco, and co-authors. The constitutional structure of the United States gives the states broad regulatory authority over medical standards. Yet the U.S. government has moved to federalize medical standards, and the federal government's legal theories could jeopardize the practice of medicine for all physicians and the health of all patients. The Trump administration has attempted to alter the balance of federal-state authority in the area of gender-affirming care in 2 important ways. Doctors could be considered distributors, and thus, like manufacturers, could face liability related to misbranding for promoting off-label uses of drugs for their patients. In addition, Secretary of Health and Human Services Robert F. Kennedy, Jr. issued a declaration stating that gender-affirming care for children and adolescents is unsafe and does not meet professionally recognized standards of care, and tried to establish a new federal standard of care. The federal government's far-reaching actions to federalize healthcare standards have had consequences for patients, physicians, and healthcare organizations. If the current district court decisions are reversed on appeal, the equilibrium of medical decision-making in the United States could shift in important ways. Federal authority over healthcare standards is appropriate in some instances, but this authority should be established using a proper legal process. Congress acting within its enumerated constitutional powers, or the executive branch acting under properly delegated authority, not by fiat or unilateral executive action. Products that pose health risks. Can litigation protect us when government fails? A perspective by Jerry Avorn from Harvard Medical School, Boston. We've been here before. A powerful and influential corporation was reaping large profits from a lucrative product that posed a health risk. Both Congress and the executive branch of the U.S. government seemed unable to correct the problem, or chose not to. Eventually, it was the victims themselves who achieved accountability. Some were represented by state attorneys general, others by aggressive private lawyers. They wielded the cudgel of litigation to demand justice, and it worked. The responsible companies were forced to pay out enormous sums for purveying products that created a health hazard. It looked as if these court cases might finally bring an end to many years of legislative and regulatory inaction that had allowed the problem to fester for so long. This summary applies to the recent $9 million judgments against both YouTube and Meta for profiting from unsafe and addictive social media products that can cause psychological harm, and also to the $375 million judgment issued a day earlier against Meta for ignoring evidence that its social media products could endanger the well-being of its customers. But tellingly, it's also the story of the successful litigation against drug giant Merck 20 years ago over its vigorous promotion of the blockbuster anti-inflammatory drug Vioxx, which more than doubled patients' risks of myocardial infarction and stroke. There are also clear echoes here of the landmark tobacco litigation of the 1990s. The parallels among these cases are instructive. When the usual processes of legislation and regulation consistently fail to protect people from products that can hurt them, litigation can sometimes redress the balance. Breaking bad news. A perspective by Brendan Riley from the Geisel School of Medicine at Dartmouth, Hanover, New Hampshire. When Tim calls, I'm floored, he says. The radio is playing Only the Good Die Young. Tim won't die young. He and Dr. Riley were high school classmates 60 years ago, but he's just been told he won't die well. Dr. Riley has seen other patients with this god-awful disease, the one Lou Gehrig and Stephen Hawking tried to make look livable, but he never knew what to say to them either. Nicholas Christakis thinks physicians have a duty to prognosticate, to tell patients their prognosis, especially when it's bad. And yet he admits that breaking bad news often requires truly an impossible combination of demands: optimism, honesty, accuracy, realism, hopefulness, humility, and foresight, all at once. Little wonder, then, that most physicians avoid it whenever possible. The neurologist who saw Tim avoided it too. A subspecialist in neuromuscular diseases at the medical Mecca, he examined Tim, pronounced his diagnosis, gave him a prescription for a new drug that might buy him a few extra months, and referred him to a clinic for amyotrophic lateral sclerosis, ALS. And that was that. But when Tim says, I can't believe it, he's questioning the diagnosis, not the prognosis. He'd noticed some soreness in his thighs. Too much time in the gym, he figured. But when his serum creatine kinase came back slightly elevated and his statin antibody test was negative, his primary care doctor requested a muscle biopsy. The local neurologist wasn't sure what to make of it. No inflammation or necrosis, just mild atrophy. Unclear whether myopathic or neuropathic. So he referred Tim to the Mecca. But ALS? Tim can do more pull-ups and squats than many men half his age. Incredulous, he asked the Mecca guy how sure he was. 99%, Tim says. Tim went back to his primary care doctor and his local neurologist, asked them both to examine him again. Normal, they said. Get a third opinion, maybe? Or a fourth? So that's what Tim is doing now. He is putting the brakes on his bad news, hoping it's fake news. No, if I've got it, he says, I'll know soon enough. God help me. In our images in clinical medicine, a 45-year-old man presented with a 2-month history of worsening pain and swelling in his right shoulder. An X-ray showed destruction of the humeral head with a free-floating humeral diaphysis. Milwaukee shoulder syndrome was diagnosed. This destructive arthropathy is characterized by the deposition of hydroxyapatite crystals, humeral head destruction, and severe rotator cuff damage. In another image, a 51-year-old woman with right heart failure presented with worsening abdominal distension and leg swelling. Examination was notable for ascites, leg edema, and a grade 4/6 holosystolic murmur. The liver was enlarged and pulsatile, shown in a video at NEJM.org. A late finding in chronic severe tricuspid regurgitation. Read more from our issue at nejm.org. Let us know what you think about our podcast. Send any comments or suggestions to audio@nejm.org. Thank you for listening.